Welcome to the Plastic Fantastic podcast, brought to you by Mr. Adrian Richards and myself, Alison Telfer. Many of you will know Adrian is one of the UK's leading breast cosmetic surgeons, and myself, one of those top nurses who does all things non-surgical. Each week we'll be interviewing all sorts of guests, all focusing on either practices, procedures, or just their fascinating lives. This is the first UK podcast of its sort, marrying the two disciplines, and we hope you enjoy.
So Alison and I are delighted to welcome to the show he's been termed as the godfather of sexual aesthetics in the UK, and is a good friend of yours, Al.
Sharif's a really good friend of mine. We probably met about 11 years. Now, before we talk to Sharif, for those of you who don't know Sharif and obviously can't see Sharif, Sharif, I would say, is the tallest Egyptian in town, very tall, very statuesque, always suavely dressed, which is why I think he has the Godfather nickname, and has a following of sort of ladies and friends behind him, I would imagine. So we've got this suave, erudite doctor in front of us. Now, I met him on a sculpture training course where you have to inject to the bone. And Sharif is an ex-orthopedic surgeon, and so all he kept saying to me was, to the bone, to the bone. Now I learn his practice is mainly working, giving people boners. Is this right, Sharif?
This is perfect way of describing it. Yes. Apparently, I have this fantasy about bones. That's why everything is about boners now. Yes, exactly. Yeah. This is what I must see in my clinic.
Yeah. From orthopedic bones now to things. How did you get there, Sharif? How did you get from meeting us on a sculpture course to where you are now?
Okay, it's a very, very long journey, but let me explain to you how I started from the very beginning. I was a plastic back home in Egypt, where I'm from, and I also loved obstetric and gynecology, and these two were my passion in medicine. When I came here, I could not find any post in NHS for any of these specialty, but I found a spinal specialty, which I joined. And I was working as a spinal surgeon at the Royal London Hospital for quite a few years. But during this period, I was also taking a lot of courses in the cosmetic industry, because this is where it started to boom, all the botox in it. And because it was such a passion of mine, I decided that, okay, this is great. I would like to do this now. So I was always doing, part-time. I was doing work in the morning at the Royal London, and then in the evening, I do all these courses, and I do these clinics. And this is one of the courses that we met, which is sculpture, injecting to the bone, to the bone. So after that, there's a specialty came to the light in the States called aesthetic gynecology. And that specialty kind of merged the two specialty together, which is plastic or aesthetics and gynecology. So to me, it was like, oh my God, this is what I always wanted, aesthetic gynecology. So I took a lot of courses, I took a lot of classes and workshops all over the States, and I came back here and I started introducing some of these treatments to Europe and the UK. And then some of these treatments were also for men, because the aesthetic andrology was something that is picked up as well. But because I'm coming from aesthetics and doing sexual, so I kind of created the name sexual aesthetics, because it didn't exist. Because all those people tell me, how do you jump from this to this, and you're aesthetics, and now you're doing sexual? So I kind of recreated the name or created the name sexual aesthetics, and now it became quite known in the area, which is the specialty that deals with both men and women.
Yeah. What are the treatments? Do you want to start on men or women, Sharif?
Whatever, ladies first. It's fine. Yeah.
I think it's always important that a lady comes first.
Absolutely.
Yeah, it is. And so tell us about her sexual aesthetics in the female, Sharif.
Excellent. So this is actually was one of the reasons that I was so passionate about this specialty, because if you think about it, and I'll be very frank because we're talking medicine here. If we say that this is the penis and this is the vagina, if you have an erect penis, it will go into the vagina, and that's a completion of an intercourse, right?
Yeah.
If you don't have an erect penis, it will not go into the vagina, and you don't have a sexual intercourse, right?
Yep.
So what's happening? There is 20 FDA approved drug to make the penis erect.
Yep.
Right? There's a lot of treatment, surgical treatment to make trying to make the penis erect, but there's nothing that looking at this part. So whether this feeling, not feeling, lax, not lax, in pain, not in pain, dry or moist, nobody cares. Nobody cares, because as long as this is happening, fine, it's fine. Nobody cares about it. And that's when I saw the massive lack of attention to this area, and it's quite undermined. And these, unfortunately, a lot of women suffer. So I will tell you, for example, a small statistic. There are 50% of women having some sort of female sexual dysfunction, and 40% of women having female sexual dysfunction to the point that it's causing them psychological distress. 1 in 5 never experienced orgasm in her entire life. 1 in 20 have a stress incontinence to the point that it's causing her a hygienic problem, yet only 14% of women ever speak about it. So
that's incredible. And is this, because obviously also when women go through the menopause and all these other changes and postpartum and all of those kind of things, so what kind of age range of women are coming to you?
I mean, you would expect me to say the older women, but actually I have women from 20s all the way to 30s, 40s, 50s. 20s, we have stress incontinence. A lot of women have stress incontinence at this age, and even up all the way to 70s. I have a wide range of women coming to me for all sorts of problems, whether it's sensitivity.
Sharif, can we quickly just run through some of the problems and the solutions? So what would you like to start with?
So I would say the most common one, which is, I tell you that 88% of women after childbirth having vaginal laxity, for example. Because if you could imagine a baby coming out, this head of a baby coming out of this small vagina, so you would imagine what happened to the vagina physiologically during this process. So vaginal laxity, and let me explain to you the importance of vaginal laxity before I go into the treatment. And I'll give you a very simple example. Women and a man having intercourse in their 40s, the women have 2 or 3 babies. The man, what people don't know is as we grow older, the sensitivity of the penis reduces. So in order to maintain your erection, you need to have quite strong stimulus, quite strong friction in the penis. So what happened is the following. A man tries to sleep with a woman who had multiple children. So she's not as tight as she used to be. So he gets an erection, he goes inside, there's not much friction. What happens? He loses the erection midway. So what happened in this scenario? He doesn't know what happened. She doesn't know what's happened, but there's definitely 2 different scenarios happening here. The man is saying to himself, oh shit, I can't do this. I'm not a man anymore. What's happening to me? And he's having all these self-awareness problems and anxiety. The woman has a completely different scenario. He doesn't love me anymore. I'm not attractive to him anymore. He must have loved somebody else. My body is horrible to him. He doesn't find me attractive. She never think for a second that he has any issue. And the treatment is a very, very simple treatment. If you manage to increase or reduce the laxity of the vagina, increase the sensitivity of the penis, you have a sorted problem. So let me tell you how I would do this for the laxity of women, for example, without surgery. Because before, what we used to do is something called vaginoplasty, which is, Adrian, you know, you just tighten the vagina surgically. But now we use different techniques. For example, we use radiofrequency techniques to introduce heat into the tissue, and this heat will shrink the collagen and make the area shrink. We also use laser technology. I also use fat injection. So I inject the whole area with fat, and that will tighten the area, but also the stem cell in there will improve the whole rejuvenation, will start the regeneration in the area. So these are the most common 3. Obviously, there are threads, there are so many things, but what we do is we look at the patient and we decide which treatment option to go for.
Okay, so that's number 1 most common problem for
Number two is the stress incontinence, for example.
Yep.
So, 75% of women after childbirth get stress incontinence. And this is, it could have a lot of examples. She could be coughing, sneezing, jumping on a trampoline, dancing, and she could leak urine. So now we deal with that with very simple treatments, like, for example, the laser treatments, like something like the O-shot, the treatments that with injection of PRP, like injecting fat, like injecting stem cell as well.
Where are you injecting that, Sharif? Because also the thing with women and our female incontinence versus men is a woman's urethra is around 3 centimeters long, whereas a man's urethra is around 16 centimeters long. And then, if I'm right, and then also with the different sort of valves and stop mechanisms, that's why we're on a losing wicket before we've even started. So where are you injecting? Are you doing it in the pelvic floor or around the urethra to tighten it? Where are you doing it? Bear in mind, people can't see it, so you can't draw us a picture.
Okay, so I'm just reminding myself. So what are you injecting? You're injecting.
Where are you injecting it?
Anterior vaginal wall. And what does that mean? You know, there's something called mesh surgery, Adrian, and you know what a mesh surgery is. So what you're doing is you're actually thickening the anterior vaginal wall, which is between the urethra and the upper wall of the vagina. So this wall, by time and delivery and hormonal changes, gets very thin. So the support for the urethra is very, very small support. So when you start coughing, there's no much support. So the pressure squeezes into the bladder, which pushes the urine out. So what happened is I thicken this region with either filler or fat, or by using the laser. The laser create insult into the tissue, and the body responds by healing this insult or by healing this tissue, and as a result, it gets thicker. So the different techniques, obviously, as I said, based on each patient and each individual cases. But you inject in the anterior vaginal wall.
Okay, so that's the two. What's number three? What's the third most common?
Sensitivity. A lot of women come to me and tell me, we don't feel anymore. And then I ask, do you know where is your G-spot? No. And
can you explain what a G-spot is?
Okay, so this is the Her Highness, the G-spot. It's a spot that everybody's dreaming about, and in every single congress we almost have one. Or we always have one lecture about the G-spot, and you end up after the lecture not knowing really whether we have a G-spot or we don't have a G-spot. But there's quite a lot of explanation. It could be it's a sensitive area in the anterior vaginal wall of the female, about maybe 5 to 7 centimeters down from the urethra. This place, of course, is quite variable, very, very variable.
Sharif, can I just ask you a couple of questions? Number one, why is it called the G-spot?
Because the doctor who discovered it, which I actually can't remember his name now, but he was, I think, Dr. G something. I can't remember. But it starts with G, so that's why it was called the G-spot. And
the second question is, so females have orgasms from different areas, don't they?
Yes.
Could you explain a little bit about that?
Okay, so one of my most common question is telling or asking the woman, do you have orgasm? If she tells me yes, I ask her, is it vaginal orgasm or is it clitoral orgasm? Because there is two different pathways for orgasm. There is the one for clitoris, which is when you rub, may I say, the clitoris from outside, you get one orgasm. But if you rub the G-spot from inside, you get a different orgasm, which we know that it's the strongest orgasm, but unfortunately, not so many people get the vaginal orgasm. This is the much more difficult one, the vaginal orgasm. Yes, it's Ernest Grafenberg. I remember.
Okay.
You were just looking that up, weren't you? You were just looking that
It's
up.
Ernest Grafenberg is the doctor, because I was so upset that I forgot his name. This guy has given us a lot. So he's the one who he discovered that anatomically, and then he kind of it was called after his name, G-spot.
Yeah. So if people are wired, is it just people are wired differently?
Wired differently.
Wired. So some people are more
Absolutely, yes.
Some areas.
Absolutely.
So there's variation.
If you want to know theoretically speaking what's in the books, yes, we should have both. We should have clitoris and we should have vagina. This is what's in the books, right? But definitely people are wired differently. And not even that, I'll go into even further details. So some people you could do the same stimulation in different people where you get different reactions. So some stimulation could work with in a different way that you do it with your finger, for example. Or if you do this with another lady, it would not work. If you do this, so every single person is quite individual, and that's why when couples know each other, this is actually part of the knowing. Part of the knowing is know where is your G-spot. So I ask her, does your partner know your G-spot? And of course, this frustrated look comes in her face. No, he doesn't. So do you know where is the G-spot? Well, no, I've tried to get it. I don't know where to get it. And quite a lot of cases, I actually show them where the G-spot is, and the nurse is holding their hands, and they feel very excited that number one, they have it. And actually this will determine what step we take afterward. So which treatment, if she has a G-spot and she knows it, or she doesn't have a G-spot and she doesn't know.
I've got a question. Well, two questions actually. One, it's a little bit like, I don't know. Okay, forget that. I'm flummoxed. So,
come on, say it. It's just talking about sex here. Come on.
That's a rarity. First of all, how do you locate it? And secondly, you don't need to practice in clinic. Just tell men the secret of finding it, and you'll be a millionaire. More of a millionaire.
You have a little map, a little. Yeah.
I tell them all the time. We know the guidelines roughly. It's in the anterior vaginal wall, as I said, about 7 centimeters down. Yes, but it varies quite a lot. Sometimes it's actually at 10 o'clock. Sometimes it's at 2 o'clock. Sometimes it's actually 3 centimeters. Sometimes it's 13 centimeters inside. So it really varies quite a lot. And the way you need to discover it, it's not aggressive. You need to be very gentle when you try to look for it. And the most important thing is the lady should not be under pressure to find it. Because if she's under pressure to finding it, or if she feels that you are insinuating that she does not feel, you completely switched her off.
Yeah. And what treatments are there for?
Excellent.
Yeah.
So when I say importance of finding the G-spot, so if there is a G-spot, that means that what I need to do is to make it more sensitive. What does that mean? It means that I need to create more nerve endings or more active nerve endings in this area. So I like to inject some stem cells in there, or of course the O-shot that we initially started with. And that could get very good result because the growth factor goes inside there, create the fibrinogen mesh, pulls the stem cell into the area, start regenerating the tissue, and also regenerating of the blood vessels that supplies the nerve endings in this area. So you end up having more nerve supply in the area, okay? But if there is no sensation in the G-spot, you inject also the O-shot because you are trying to regenerate the rewire again. But if there is a sensation in the G-spot, then what you need to do is you can do the O-shot to increase the sensation, but you can do something called the G-shot with the O-shot. And what is the G-shot? It's injection of dermal filler into the G-spot. And the aim of that is to increase the surface area of the G-spot. So instead of it going down by like 5 millimeters down to touch the tip of the penis or the head of the penis or the shaft or whatever, it depends on where it is, it actually going down like maybe 0.5 centimeter or 1 centimeter. So touching it with the penis is much, much easier, which means a lot of friction, which means a much more stronger sensation.
It's like putting a signpost for the gentleman, isn't it? It's kind of like, here it is. So he knows when he's hit it, and it's probably quite nice for him as well, I'm guessing, if there's another bump in the road.
Well, I think for men it's much more satisfying to feel that he's really making his woman feel, and she's really, you know, moaning, and she's really feeling what's happening there, as opposed, you know, he's doing all his work and she's just looking at the ceiling and just looking around and nothing is happening.
Are there some women who just cannot have orgasms?
Yes, of course. Yes.
Is there anything you can do for them?
Yes. I try with the O shot first, and then I step it up to maybe to stem cells, and then I go to two different routes. I go regenerating the tissue, but also I try to educate them on how to find them and how to put their self into the right mental state to find it.
Yeah, and you mentioned the O shot a couple of times.
Yes. So the O shot, basically, which is the treatment that I'm very famous for. I introduced that treatment from the States. It's injection of the vagina with PRP. And as I explained earlier, what happens when you inject PRP? We know that platelet rich plasma, or PRP, in your blood there is platelet. We try to concentrate this outside by the means of centrifugation. We get these platelet, we inject it into one place, and these platelet open up and release something called growth factors. And the growth factors come together and cause something called fibrinogen mesh. And if you'd like to see this with your own eyes, remember when you are a child and you hurt your knee and there's a little scab on your knee, and you're trying to pull this scab to see what is sticking the scab to your knee. You don't understand. You're very curious, right? So there's some yellow goo in there. And this yellow goo is actually the fibrinogen mesh. So what happened after the fibrinogen mesh creation? This fibrinogen mesh starts to cool the stem cell that runs inside your body. And the stem cell comes and starts regenerating the entire area.
So that's likely to make your orgasms more, or
absolutely
hasn't?
So what happens is you're regenerating the tissue. By regenerating the tissue, you're increasing the blood supply to the tissue, and also you're increasing the nerve endings is having more food by the amount of blood that it's come, and also being regenerated, because part of the PRP injection treatments that we inject, for example, a lot of women, you do a lot of breast enlargement, Adrian, for example.
Yep.
Yeah. So a lot of women after breast enlargement, they lose their sensation. Yep. So one of the most common indications is we inject PRP around the breast, and we regain the sensation of women again by regenerating the nervous tissue around the breast. So by doing that, you're enhancing the regeneration of the nervous tissue in the G spot, or even the clitoris, and you're regenerating that, or increasing the sensitivity again.
So let's pretend I'm a patient. So I come in to see you and said, Dr. Wakil, I don't feel anything. I don't feel like I have orgasms that I feel like I deserve, and all of those things. Actually, quick interlude. I think it's really interesting. I think our generation are very different. You know, when I was growing up, our mothers, it was very sort of taboo. You don't talk about it. This isn't something we talk about. Whereas, you know, I remember years ago saying to my mother when I was a teenager, what's a period? And she said to me, she pulled down her newspaper that she was reading, and she said to me, darling, it's a length of time. And that was it.
Oh.
So I think it was a conversation we didn't have. So I'm now brave enough. I've come in to see you. What's the process? Consultation, treatment, then when do you advise that I try to have an orgasm? What are the costs? What's it going to cost me? And all of that kind of thing. Okay. So this takes me to a very important element of my treatment protocols now. So over the time, after I introduced, did quite a few treatments, and I've also managed to design a few machines for different companies that exist now with the radio frequency machines and so on. I managed to create a protocol, which is called the O concept protocol, and I trademarked it, and it's actually becoming quite famous recently. So the O concept protocol is a lot of questionnaires that the patient asks or answer, and based on these questionnaires and the history of the patient, the age of the patient, the state of the patient, I design a plan.
And this treatment plan is very well bespoke to every single individual. You'll never find one like another one. And it's based on this particular person. So let's say, as you said, you're a patient, come to me, I give you quite a lot of questionnaires to answer about almost every single aspect of your sexual life and your sexual feeling. And I take your medical history, and based on that, I will say, okay, so our plan or my all concept protocol for you is X, Y, Z. You're going to have the O shot, you're going to have the laser, you're going to have this. And we start the treatment plan, and you fill a questionnaire, which is a pre-treatment questionnaire for the most dysfunction questionnaire. And then we keep following the results after each session. And at the end, you reach the state where you tell me, okay, it's absolutely fantastic. This is finished. This is finished. This is finished. I'm done. That's great. Then what I tell patients, okay, so now we fix that problem, but you need to understand that we are in a race against age.
Yeah.
So you don't think that you took that and that's it, off you go, and for the rest of your life. You need to understand that just like you look after your face, you look after your hair with a hairdresser, you look after any organ in your body, you need to look after your vagina health regularly.
Good. Okay, so one more question on women before we move to men, because men need a little bit of it. Why can some women, is there a refractory period between orgasms? Is there a period between orgasms? So some people seem to have a much shorter period before they can have another one, basically.
This is very, very individual. I know people who can have 2-3 orgasms in a very, very short period of time. And I know people that, I mean, once you reach orgasm for women, the second orgasm is much easier. A third orgasm is much easier. But the situation is very different for men. But women, if you manage to reach the first one, then the second and the third is much easier to arrive because you're in a state there already. But the difficulty really is to reaching that. So let me say you're climbing a very big mountain, and then now you're going slowly down the mountain, so it's much easier to go downhill. You will have 1 or 2 or 3 or 4 even orgasms if you keep the stimulation on, because you're already in that state. But for men, it's very different.
Yeah. Okay. Al, anything else on women before we move to men?
No, I think I'm quite happy that I've got to climb a mountain and then just keep going back up the peak really quickly, and
Absolutely.
then I'll be good. So when we talk about tall things and peaks, let's move on to men. And let's move on to men. And obviously when I was looking, I mean, I know you, Sharif, but I just thought I'd have a look at all of your sort of stuff. And you've done some work with some real celebrities when it comes to erectile dysfunction and things.
Yeah, quite a lot. Yes, it's true. Because it's a situation that can affect, whether you're celebrity or not, poor or rich, it affects all men.
So you say you've seen some celebrity bits during your time?
I've seen quite a lot, to be honest. I mean, A-list celebrities, but of course I can't say anything for the confidentiality, but some of them actually came on public and spoke about it. So
are you allowed to talk about any in particular or not?
Well, I think there's quite a few people who came on the Sun magazine, like for example Sarah Ian Botham, or there's quite a few others, but I think I really admire them very, very much for coming forward and speaking about that, because it's really it showed how they are really keen to raise the awareness about these issues and these problems. It's fantastic to become ambassadors like this and talk about solutions that exist. It's very, very good, and I'm very, very proud of them.
So Sharif, are these gentlemen, because I don't know, I used to work in urology, but back then it was gentleman has a problem with erection, goes to his GP, gets prescribed by Viagra, and Viagra now you can get a low dose, I think, over the counter in pharmacy. Are these people that have tried your more normal medical techniques that are coming to you, or is it just because you do have this speciality and this name behind you that they're coming because you can do something different and better than what's out there?
Absolutely. I think most of the people that come to me, they tell me, this is a phrase that I always hear: I'm sick of pills anymore, or the pills doesn't do anything anymore, or I don't want to be on pills because of all the side effects, or I don't want to have any, pharmacological stuff inside my body at all. And we all know that if the Viagra is going to work now, it's most likely, if you keep taking it for a few years, it's not going to work. I know patients actually come and they started with 25 milligram, went to 50 because it starts to wear off, and then it starts to go to 100, and it starts to wear off, and they went to even to 200, which I think it's crazy. But they tell me they even took 200 and still not doing anything, which is, and of course tell them off really that they're taking 200 milligram. But eventually there's something called neutralization happen, and then it doesn't really affect them anymore. So that's a group of people. Another group, they tell me, no, I would never ever touch any medication. I want to have something natural. And that's what I'm very famous for. Natural, which is regenerative and functional medicine.
Yeah. Can we just recap? So the reason basically people get erections is because blood is allowed into the penis. It can't get out, so it fills up the cavities. And so could you tell me, number one, how common is sexual erection issues in men, why they get it, and what the causes are and what the solutions are for them?
Okay, so let me explain to you. It's a very good thing what you said, how the erection happens. Number one, you get a stimulus, and this stimulus causes gushing of blood into the penis, and the smooth muscle is ordered to relax, which is the cavernous spongiosum in your penis. It's ordered to relax, to kind of absorb all this blood coming. So when all this blood comes in, a mechanical stoppage of the valve happen at the end of the penis because of all the blood that comes in. So mechanically the valve is stopped, and as a result the blood doesn't leave the penis, and it remains for the entire procedure until you reach the orgasm. Then it's ordered to relax, and it relaxes the blood backward from the vein. And that's why one of the problems is called venous leak. And venous leak is that this valve doesn't really control the blood or stop the blood. It's a very, very small amount of patients, but still exists as one of the reasons. So this is how erection happens. So number one, what are the reasons? There's quite a lot of reasons, mainly cardiovascular problems, diabetes, hypertension or high blood pressure, prostatectomy, injuries on the nerves. Stress is one of the biggest reasons as well. So there's quite a combination of reasons really that could cause the erectile dysfunction.
And I believe if it comes on in a man, it can be an indication that you've got cardiovascular disease.
Actually, it's the earliest. Thank you so much, Richard. It's very correct. Actually, it's the earliest sign and that's why we always tell the patient, okay, we need to do some cardiovascular checkup on you, because that's the earliest sign of any cardiovascular problems.
Because it's the same thing, the vessels getting clogged up, not enough blood getting in. It's the same pathology.
Absolutely. Yeah.
Okay, so how common is it?
So in a 40 years old is 40%, 50 is 50%, 60 is 60%, 70 is 70%. So if you look between 40 to 70 is 52% of men have one form of erectile dysfunction. Because erectile dysfunction is very elastic. Sorry to interrupt you, but it's very elastic. So it's people from having just not very strong erection to people who have no erection whatsoever.
Okay. And obviously, as you said, it's a big thing for a man and it's a big thing for a woman. It causes a lot of unhappiness in relationships, doesn't it, Al?
Yeah, it does.
It does.
I mean, it does. And it comes down to, I think, because often when people get to that point in perhaps their marriage in their 50s, they've been together a long time, communication isn't always great, emotional intimacy isn't always great. So people don't feel comfortable in talking, and a lot of people will just go, and it probably coincides at a similar time when the woman's going through the menopause. So there's just this, just let it go. So it'd be interesting actually also to know, Sharif, how many of these gentlemen that come to you are in newer relationships, and how many are in longer term relationships?
I was actually speaking this morning. I was giving another interview this morning, and the journalist asked me the same question, and she told me, what is the profile of these patients? And actually, it's a big wide range. So you get the patients who tell me that I don't want anything to be sent to home at all. I don't want my wife to know anything about this, or I'm taking these treatments at all. And you get the patient that he's actually coming with his wife. And these are two completely set of even way of dealing with them. Because somebody's coming with his wife, that could mean either two things. It could either they mean that they're so much in love and she's really compassionate about him, and he really doesn't hide anything from her, and he's very happy, for her to know everything, and they're sharing this journey together. Or it could mean that she's the one actually bringing him. Yeah. And he's very upset and very annoyed that this is happening, which is easily sensed during the consultation. And now I know that there's a big stress element in this relationship and in this erectile dysfunction state.
So if a man and a woman come, it's either good news or bad news for their relationship.
Either good news or bad news. It depends on their consultation, how it goes. Exactly. The questions, I ask certain questions, and then I start to to understand what's happening. And sometimes I ask for the man to be alone, and I could tell her, okay, can you please just give us a few minutes by yourself, and you could kindly wait upstairs. We'll make you a nice cup of tea, because I know that he's being so much stressed and squeezed, saying stuff.
Yeah, I had a patient who came in for liposuction, and she was too heavy. She came in with her husband, and he was sitting on in the background. And I said, look, I can't do liposuction because you're basically too heavy. Right, 30. And she said, well, I've just won some money, come into some money, and I want liposuction. If I pay you double, will you do it? I said, no. And then she says, you won't do liposuction on me? And I said, no. And then she said, well, do you do penis enlargements? And I said, why? Why are you asking? And she turned around, pointed at him and goes, he needs one.
Oh.
And he was not expecting it.
Absolutely not.
He went from uninterested to hyper interested in a millisecond. So I understand the relationship between the
I know. It's a very complicated relationship, I have to say. Very, very.
I was telling Adrian the story the other day. This is when I was a sister back at Bart's, and this big, typical Afro-Caribbean woman walks in with this little tiny Afro-Caribbean man, and he sits down in the chair in front, and she sits behind, and I'm sitting there saying, okay, so what's brought you here today? And he doesn't speak. She starts, he doesn't have an erection. I want him to have an erection. He's not having an erection. And so I could feel this kind of, so I said to her, why don't you leave for a minute, just because I need to speak to your husband because of confidentiality on my own. So as soon as she leaves the room, he goes, I don't want to have an erection with her. I can get an erection, but not with her. And, this is the sort of, you're dealing with those sensitivities. So go on, tell us. So you've got the husband and wife, and then you've got the gentleman coming to you saying, please don't send anything to my home.
Yeah.
Absolutely. This is exactly the kind of patient that I see day in and day out in my clinic. And once you have this kind of patient profile that you mentioned, Alison, then it's really much more difficult to deal with, because you often have to turn psychiatrist as well as physician in treating this patient. It's not just about how to handle the issue as well, because it's a lot of psychological pressure on him. And I often ask my very famous question, do you have other sexual relationship that you are good at? And quite often they say, well, actually, yes, I don't have this issue with somebody else.
What's that question you ask?
I ask them if they have extramarital relationship or extra, outside their girlfriend relationship.
Not when their wife's there, though.
No, of course not.
You're quite safe, Adrian. You're quite safe.
Good. So
intelligent like that.
Let's get down to nitty gritty. So you've got a middle-aged man who's got an issue. Viagra's not working anymore. or doesn't want to use it, what can you do?
Okay, so back to the old concept. And I just want to tell you that the old concept, just like when we started doing the face, we do, okay, let's start with Botox, 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 Botox. Every patient comes to me, Botox, Botox. And then we say, oh, filler. Okay, let's do filler, 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 filler. Now, the patient comes to you, okay, so we do a little bit of Botox, a little bit of filler, we do a little bit of PRP, we do a little bit of threads. So that's exactly what I do for sexual dysfunction. That's the old concept. It's very, very comprehensive based on his specific need. So, okay. So sensation is down. I increase the sensation for his penis, for example, to start having it. After answering all the questionnaire, I'm able to say, okay, so your problem is you have a weak erection. Okay. Number two, you have a inability to maintain erection. There is a little bit of premature ejaculation. There is so I decide which one we're going to go for, or what is the exact indication for, and I say, okay, for this one we'll do this and this. For that one we'll do this and this. For this one we'll do this and this. And this is the plan that we're going to do for you. And we kind of split the treatment or the plan based on his availability, based on is around or from the country or not, because I see a lot of overseas patients. So I cut it according to that.
So let's start generally. So one problem is they can't maintain an erection. The solution often is what?
Okay, so what I do a lot of is the P-shot and the stem cell injections. So I do a lot of stem cell injections, and that causes the initial regeneration of the tissue. So I regenerate the penile tissue, I regenerate the cavernous, I regenerate the blood vessels, I even regenerate the nerve endings to increase a little bit of sensitivity there. We also use something called shockwave. We use radio frequency, we use carpoxy there, we use quite a lot of other treatments. We even use Botox for erectile dysfunction.
Do you use anesthetics?
I use anesthetics, and usually I have patients who actually go to sleep on the table. They don't feel anything.
Right.
Because I use a very strong numbing cream, or worst case scenario, I can do penile block. But usually, numbing cream is more than enough. And I know the idea. I know what you're thinking exactly, and I can see you smiling almost. But what's happening is the idea of you having a needle coming close to your penis is a very uncomfortable idea, right?
Yeah.
But with all honesty, nobody feels anything. They kind of feel the anxiety rather than the actual thing. And I have a little trick that I do, which I actually inject, and I tell him, okay, I'm going now. And he keeps anticipating the big pain, and then I inject everything, and I say, okay, it's all done now. And he looks at me and says, what do you mean? What do you mean? It's done? I said, yes, it's done, because he's expecting the very big pain. Mm-hmm. But when he feels some sort of pressure, he doesn't really get anything. He doesn't, okay, this is nothing.
Well, that's good. And premature ejaculation?
Well, premature ejaculation, now we're treating it with two things. Number one, we're doing dermafiller. So we're injecting the glands with dermafiller, and that's kind of reducing the sensitivity of the penis and of the gland specifically, and that makes him. So we're increasing the sensitivity on the shaft, but reducing the sensitivity on the glands to make him able to last a bit longer. The other things, we are increasing the strength of the pubic muscle, and that's the muscle that control the actual orgasm. So if you're able to squeeze that hard enough, you stop the orgasm.
Where's that muscle then?
It's in the area between the anus and the scrotum, sort of.
So the perineum.
Yeah. Mm.
It's when you let me tell you, when you're in the toilet trying to pee and somebody knocks at the door, this is the muscle that you use to stop the urine, because you don't want the body to open the door while you're peeing. So that's exactly the muscle.
Can men and women? I know pelvic floor exercises, are they good for women? Are they good for men as well?
Very good for men. Yes, they do. But the only issue is a lot of people don't know how to exercise, so I kind of guide them through what to do in order to have these exercises.
Well, tell us what we've got to do, us men and women.
Okay, so number one, you need to identify the muscle. So you need to say, okay, where is this muscle? So I am peeing now, and now I'm going to stop the pee. Okay, so what is this muscle? Can you see that? Can you feel that muscle? Yes. Okay, can I do it anywhere? Yes, you can do it anywhere. So how can I do it? So a lot of women, they say Kegel exercises from them. And I tell you that the Kegel exercises, if you ask any woman, almost 90% of women, if you ask her Kegel exercise, they tell you it's rubbish. It doesn't work at all. Yes and no. And let me tell you why yes and why no. Yes, because they don't do it enough for it to work. And no, because if they do it enough, it actually will work. But in order for it to work, you need to have at least 2,000 exercises a day in order to have a strong pubic suggest muscle. So tell me how a working mother with children going to work, coming to do the home, coming to do that, will have time to do 2,000 exercises a day. So
I've just done 45 since you've been explaining that to me.
Fantastic.
Well, well done. Well done. So we should all be doing those exercises.
Absolutely. Absolutely. So I always tell them, try to match it to a daily routine that you do. For example, you're going to work. Yes, how do you go to work? By car or by bus or by train? They say, well, I go by car. Okay, when you're sitting in your car, make it a habit. Once you sit in the car, you start with the exercises. 1, 2, 3. You can be doing anything else while you're doing the exercises. It's something you can multitask. So you know that during this 40-minute strip, you actually probably would have done about 500 exercises.
Yeah.
And then you have another 40 hours coming back. This is where you do the other 400 or 500.
Yeah, that's a good idea. Someone said do it when you're brushing your teeth.
For example, but this is going to be too fast because I usually brush too fast.
I'll be losing count whether I'm brushing, squeezing, it's like rubbing your head and patting.
Exactly.
Like a helicopter.
Sadly, we need to come to an end soon. So I guess before I go, I want to know what are your patient numbers like, Sharif? How many days are you seeing patients, and when are you planning to go back?
Well, we don't know yet. We're still waiting for the government. We're hearing some stuff about 15th of June. I'm not sure about this. What do you think, Adrian? Is that something?
Well, they say the 4th of July, don't they, Al? I think that's the date.
15th of June. They're saying for non-essential shops, but we're not really a shop.
Yes.
No.
Well, there is quite a lot of demand on this now, especially for the sexual dysfunction during this COVID time. But you
were going to tell us about lock-in. You're going to tell us about the lock-in. Something about the lock-in.
Lock-in.
Yeah.
Lockdown. I think we were saying there's been more demand since lockdown.
Yeah.
Yes, actually, what happened during the lockdown, because men are now faced with a very serious situation, which is they ran out of excuses, being tired and at work all day, and exhausted, and they have a meeting early in the morning, and all these kind of excuses. So and also for women, she can't say she's been doing all day work, or she had work and coming at home. So eventually couples who've been trying to avoid that for different reasons, or we're not very comfortable in this area, started now to face the reality that they have to do it. And then when they started doing, then they started seeing a lot of problems. So my virtual consultation has actually increased dramatically during this lockdown, because a lot of male and female starting to see the problem. And it's the contrary that happens. A lot of people thought that sexual relationship will increase dramatically during this lockdown because people are alone doing nothing. But what happened is actually we've seen 48% reduction in intimate relationship according to statistics. So
that is interesting, isn't it? Because you always heard that in power cuts and things that it went, is more.
Having said that, we're still expecting. I mean, China in particular is still expecting a massive boom in babies in the next 9 months or something, and I think quite a lot of countries could see that.
Yeah.
I think it comes down to that saying though. They say, she's brilliant, you know, country and western singers really say it as it is. So, you know, with regards to decreased sexual sort of relations, it might be because how can I miss you when you never go away? Which is one of Dolly Parton's famous songs.
Yeah.
So,
Exactly.
you know, we desire the people we don't have. So desire is something about something you don't have. If you have it, you can't desire it. So it's probably a part of that.
Yes.
So which may be affecting the corona boner. But hopefully it will bring business back to you, Sharif, when we do reopen.
So all of us, I hope, to all of us. I hope. We just need our patients to be happy and having a good, satisfied, and satisfactory life, especially in this area. Because when people ask me, "Oh, you do this, you work," but it's not about the bed problem here. I'm not in the business of making sex better. I'm in the business of making the entire life of everybody. If you see the amount of people or patients cried in my chair telling me, "Oh my God, you saved my marriage. You saved my relationship." I'm very, very grateful. Now I can go back to my dance stuff and be human again, because this was very important for her, but she was leaking everywhere. Or my partner was really almost leaving me, and now I can feel, and he's very happy about it. So we're almost healing an entire society. It's not just about healing a relationship in bed.
Brilliant. Well, I thank you very much. I know you are the pioneer of this in the country. Fascinating to talk to you. And I agree, Al, I think you agree that it's a very important but under-discussed.
Absolutely. Absolutely.
And, you know, very important for general happiness. Would you agree, Al?
I really do. I think, and also because I always say this, people are living life longer. We're expecting to have sexual relationships for longer, you know, and all of those things. You've been absolutely brilliant, Sharif. I knew you would be. Thank you so much.
Thank you so much for having me. I really, really enjoyed it. And thank you so much.
I'll speak to you soon.
In your show. Take care. Take care.
Bye, darling. Bye.
Bye. Bye. Bye.